We will discuss hypoadrenocorticism or Addison's disease in dogs and cats. First of all, we need to know about the normal physiology of adrenal glands. Adrenal glands are present on the top of the kidneys, and their structure is composed of outer cortex and inner medulla. The cortex is divided into three layers starting from outwards to inwards. First one being zona glomerulosa, which is the outermost, the middle layer zona fasciculata, and the innermost layer zona reticulata, which is present right next to the medulla. The glomerulosa layer secretes mineralocorticoids, primarily aldosterone. The second fasciculata and the third reticulata layers, these secrete glucocorticoids, primarily cortisol, and androgens or sex hormones. So I will be referring to aldosterone and cortisol, not mineralocorticoids or glucocorticoids every time. And I will repeat, the outermost glomerulosa layer secretes aldosterone. The other two layers of the adrenal cortex secrete cortisol and androgens. The adrenal medulla is responsible for the secretion of epinephrine and norepinephrine. A quick review on the hypothalamus HPA axis, which is hypothalamus, pituitary, and adrenal gland. Hypothalamus secretes corticotropin releasing hormone CRH, which stimulates the pituitary corticotropes to secrete ACTH. Now ACTH is very important because we will come back to it again and again. This ACTH will stimulate the adrenal gland to release cortisol. So this is the tricky part. ACTH controls or regulates the secretion of cortisol only. That means ACTH will act on the innermost layer and the middle layer of the cortex. These two layers are ACTH dependent. The outermost zona glomerulosa that secretes aldosterone is RAS dependent mainly. So ACTH does not regulate the secretion of aldosterone because it depends on the renin aldosterone angiotensin system. This basically means that when the pituitary gland is dysfunctioning, that is, it is not secreting enough ACTH, the ACTH dependent layers will both atrophy eventually, but the glomerulosa rarely atrophies because it relies on RAS. So to simplify, ACTH basically regulates the secretion of cortisol, whereas aldosterone is not dependent on the ACTH released by the pituitary. Now I will tell you the functions of both the hormones, aldosterone and cortisol. The detailed list of functions of cortisol is discussed in the Cushing's disease or hyperadrenocorticism. So first of all, the function of aldosterone. Aldosterone is mainly responsible for sodium resorption. That means it tends to retain sodium inside the body. And as we already know, water will always follow sodium. So if sodium is resorbed or it is retained in the body, as a result, water will also be retained. So aldosterone tends to retain sodium and water in the body and prevent its excretion. Now, very important function of aldosterone is to excrete potassium and maintain muscle and nerve function. Lastly, it is also responsible for maintenance of acid-base balance because it regulates hydrogen ion or hydronium ion excretion. So it is responsible for the retention of two things, that is sodium and water, and excretion of two things, potassium and H positive or hydronium ion. The very important part here is sodium and potassium. Now, the Addison's diseases has been classified into primary and secondary, just like other metabolic diseases. Primary is the most common cause. Primary Addison's disease is caused due to the destruction of adrenal cortex, which decreases levels of both glucocorticoids, which is cortisol, and mineralocorticoids, which is primarily aldosterone. And the most common cause of primary Addison's disease is immune-mediated destruction of adrenal glands. If there is immune-mediated destruction, this means all the layers of the adrenal cortex are destroyed. So in primary Addison's disease, there will be a deficiency of aldosterone as well as cortisol. In secondary Addison's disease, there is decreased ACTH levels, but the adrenal functions are intact. So in this case, there will be a deficiency of cortisol but not aldosterone. Remember this, aldosterone will be normal in secondary Addison's disease. Why? Because the zona glomerulosa layer does not really respond to the ACTH levels, whereas ACTH controls the fasciculata and the reticulata layers that are responsible for secretion of cortisol. So if there is decreased ACTH, there will be decreased cortisol, but aldosterone will be normal because it relies on the RAS. Now, the potential causes for secondary Addison's disease are destructive lesions in the pituitary, because remember, pituitary secretes ACTH. Or there can be iatrogenic causes, prolonged or high doses of steroids that will suppress ACTH. So in the hypothalamic pituitary adrenal axis, the cortisol, remember, the cortisol is responsible for sending a negative feedback to pituitary as well as hypothalamus so that they do not secrete their respective hormones. Another cause of secondary Addison's disease is megestrol treatment in cats, which is not that important. There's a very important point for Navle, that is primarily young to middle-aged, roughly up to 4 years, females are most predisposed to Addison's disease, especially poodles. Now, the clinical signs for Addison's disease. First one, vomiting and diarrhea. Cortisol has anti-inflammatory properties, so it will maintain the GI lining integrity and increased secretion of mucus and bicarbonate. But in Addison's disease, there is decreased cortisol, so GI mucosa is prone to damage, which will also lead to gastrointestinal bleeding. Now, we need to remember that cortisol is a stress hormone, which means it will prepare the body for endurance survival. I will first discuss the normal functions of cortisol, then we will be discussing the clinical signs of Addison's disease. Cortisol is responsible for increasing blood glucose levels and decreasing glucose uptake by the cells, which is completely opposite to that of insulin. Cortisol will also increase production of glucose in the liver and increase accumulation of glycogen, which is a reserve, in the liver, so that the glucose produced is also stored in the hepatocyte. So it will increase the production of glucose, it will increase the storage of glucose in the form of glycogen in the liver. It is also responsible to increase the breakdown of lipids, fats, proteins, and the non-carb sources. Cortisol is also responsible for increasing sensitivity of blood vessels to catecholamines like adrenaline and noradrenaline, to increase BP so that blood is available to vital organs during stress. Another very important function of cortisol is that it leads to suppression of inflammatory and immune reaction. So it will cause immunosuppression. Cortisol also delays wound healing and decreases collagen synthesis, which will make the skin fragile and more prone to bruising. The other less important points are that cortisol will lead to stimulation of melanin production. It will inhibit hair follicle cycle and arrest hair growth, just like in hypothyroidism. It will also stimulate enzymes in hepatocytes that cause hypertrophy to compensate for increased metabolic demands due to excessive cortisol. Lastly, cortisol inhibits ADH, antidiuretic hormone, also known as vasopressin, to prevent excessive water retention. So these were the basic functions of cortisol. These are not that important, but it forms a basic to understand the concepts related to Cushing and Addison's disease, and you can always refer back to these whenever needed. Now we will discuss about the clinical signs of Addison disease. First one is vomiting and diarrhea. These are gastrointestinal signs, because normally cortisol was supposed to maintain the gastrointestinal integrity. If there is decreased cortisol, this means the gastrointestinal mucosa is damaged now. That barrier has been damaged. So it will lead to irritation, vomiting, diarrhea. Since cortisol levels are low, the blood glucose will be low, the energy will be low. So the animal will be lethargic. There will be anorexia, weight loss. There will be PU and PD to compensate for the decreased sodium resorption and water loss. Very important points: hypovolemia and bradycardia. Hypovolemia occurs due to dehydration, and bradycardia because there is hyperkalemia in this case. Where does this extra potassium come from? Because aldosterone was responsible for excretion of potassium, and in Addison's disease there is decreased or deficiency of aldosterone and deficiency of cortisol. So in this case, the potassium will be retained in the body, and the role of potassium on heart is normally after contraction of heart, cells have to reset or repolarize so they are ready for the next beat, and this reset requires potassium efflux or potassium leaving the cell so that the chambers fill again, like the heart fills again. But in hyperkalemia, what happens is the potassium efflux is not happening because the levels of potassium are already high. So there will be slow repolarization and relaxation. That means slow conduction of heart. That means bradycardia. So you can either cram that bradycardia occurs due to hyperkalemia or actually understand the basic behind it. But for Navle, all you need to know is vomiting, diarrhea, lethargy, PUPD, hypovolemia, and bradycardia. So suspect Addison's disease in an animal which is in a hypovolemic shock with bradycardia or gastrointestinal signs. So this gives you a basic idea of Addison's disease. Now the blood picture will reveal normocytic normochromic anemia, non-regenerative anemia. Why? Where does this anemia come from? Because there is gastrointestinal bleeding. There will be obviously hyperkalemia, hyponatremia, and these two are characteristic of Addison's disease. The normal sodium to potassium ratio is 27:1. But in Addison's disease, the ratio is less than 27:1, and this is also very important. Sometimes they put this thing in the question that the ratio of sodium to potassium would be given, or you will definitely see decreased sodium or increased potassium. Chloride ion will also decrease, because just like how water always follows sodium, chloride also always follows sodium. So if there is hyponatremia, the chloride ion, it will also be decreased. Now the Bun-creatinine will be high. Why? Because there is hypovolemia. This hypovolemia leads to azotemia, because there is decreased blood flow to the kidneys, so there will be increased Bun-creatinine mostly. It is also said that in Addison's disease, signs are similar to a liver disease as well. There will be decreased Bun sometimes, mostly it's increased. There will be hypoalbuminemia, hypocholesterolemia, which means both albumin and cholesterol will be decreased because of its wastage or due to gastrointestinal bleeding. The liver enzymes will be increased mostly, and there might be microhepatica, or this liver will shrink. This wasn't that important. The most important point was in the blood picture was hyperkalemia, hyponatremia, decreased chloride ions, increased Bun, and very important, hypoglycemia. And the reason for hypoglycemia is that cortisol increases blood glucose. It reduces its uptake by cells, and it releases more glucose into the bloodstream. We read that it has opposite function to that of the insulin. So hypoglycemia is also very important. Now for the diagnostics, specific test for detection of Addison's disease is ACTH stimulation test, which is gold standard. In this test, what we do is we measure cortisol levels in the morning, then we give ACTH. We give exogenous ACTH through IM route or ACTH gel. We apply ACTH gel and then measure cortisol levels again 2 hours if gel was administered, 1 hour after if IM injection was given. But you don't need to remember this. All you need to know is first the cortisol levels are measured before exogenous ACTH stimulation. Then after the ACTH has been administered, we again measure cortisol levels. Now what will be the observation after ACTH stimulation test? For primary Addison's disease, the aldosterone level will decrease, while the ACTH level, endogenous ACTH, not the exogenous one. We already gave the exogenous ACTH for the test. Now we're measuring the endogenous, the one that is produced itself by the pituitary. The endogenous ACTH level will increase. I will tell you the reason. So the aldosterone decreases because in primary Addison's disease, all the layers of the cortex are destroyed. So there will be decreased cortisol and decreased aldosterone, both. Now, why is ACTH level increased? Because the pituitary overproduces ACTH. There's a deficiency, so that deficiency sends a feedback to the pituitary that you need to produce more. So the pituitary tends to produce more ACTH. And since the adrenals are non-responsive, the adrenal in primary, we already know that the adrenal is damaged, so the pituitary is normal and it tries to push the adrenals. While in secondary Addison's disease, the aldosterone level is normal. Why? Because in this case, the adrenals are intact and the aldosterone is regulated by RAS, not by ACTH. So ACTH administration does not affect aldosterone. But in this case, the ACTH level will decrease because the pituitary is the problem. The pituitary cannot produce enough ACTH, so the ACTH, endogenous ACTH, will be decreased. Now, dogs with Addison's disease show no increase in cortisol concentration in response to ACTH in both the cases. The only difference here was aldosterone and ACTH levels. The cortisol will remain low in both cases, and I will explain it to you why. Because in primary Addison's disease, the adrenal glands are not functioning properly, they're damaged. So they will not produce cortisol. In secondary Addison, what happens is that the pituitary, since it does not release ACTH, long term what happens is eventually, because there's no stimulation from ACTH, the part of adrenal cortex that produces cortisol, that means the middle and the inner layer, will eventually atrophy. This is important. The atrophy part is important for Cushing's disease as well. So in the secondary Addison, the reason why cortisol again will be decreased is because since there is no stimulation from the pituitary gland in the form of ACTH, eventually the adrenal gland will atrophy. The part that secretes cortisol will atrophy. This was all related to the diagnosis. Now the very, very important part is Addisonian crisis. What is Addisonian crisis? Most of the clinical signs of Addison's disease are vague and mild, like diarrhea, lethargy. They're not noticed initially, but some dogs develop a life-threatening condition that is characterized by hypovolemia and hypotension. So this is an emergency condition, and for Navle we need to know about Addisonian crisis as well as its treatment. Just like in hypothyroidism, we read about DKA, which was also emergency. Now the treatment of Addisonian crisis. Number one is fluid therapy, 0.9% NaCl, which is isotonic saline. This will correct the hypovolemia, acid-base balance, hyperkalemia. The extra point is if there is hypoglycemia, you can give IV dextrose. In case of arrhythmia due to hyperkalemia, we can give 10% calcium gluconate. But the main important point to be remembered is 0.9% NaCl, normal saline. Second point for the treatment of Addisonian crisis is administration of glucocorticoids. So for this you have to give dexa or prednisolone. You can also give hydrocortisone. Hydrocortisone has glucocorticoid as well as mineralocorticoid action. So action similar to cortisol as well as aldosterone. Third point is administration of mineralocorticoids for primary Addison's disease, because only in primary Addison's disease there is deficiency of aldosterone or mineralocorticoid. They are both used synonymously. So for this there are two drugs, fludrocortisone, second one is DOCP. You don't need to remember the full form of DOCP. Just remember the two important drugs, fludrocortisone and DOCP. I will quickly summarize the treatment of Addisonian crisis. First one is fluid therapy, 0.9% NaCl, which is isotonic saline. Number 2 is administration of glucocorticoids, that is dexa or prednisolone. If you want both gluco plus mineralocorticoid action, then you can give hydrocortisone. Third one is administration of mineralocorticoids for primary Addison's disease, that is the two drugs are fludrocortisone and DOCP. Now, the maintenance treatment for Addison's disease is: first, give glucocorticoids. Second, give mineralocorticoids, because these are the two hormones that are deficient. So for the first one, send the pet home on prednisone or prednisolone. For the second one, administration of mineralocorticoids, give fludrocortisone. Now there was this important point that was mentioned in vet prep, that DEXA and DOCP, they do not adversely affect the results of ACTH stimulation test, which means in case of emergency, if you first treat the animal with DEXA or DOCP, because it's emergency, you need to treat first. You can confirm or perform the ACTH diagnostic test later on. So this means that you can treat the animal first and still be able to diagnose the disease later on. But prednisolone, cortisone, these other drugs, they lead to false increase of in the test results. So this means that if you give prednisolone, etc., if you suppose a dog came to you and then it was emergency, you treated the dog. Now you just want to, once the dog has stabilized, you want to confirm it if the dog had Addison's disease. You cannot go for this test because it will give misleading results. This was mentioned in vet prep. There was another point mentioned in vet prep, that in Addison's disease there's hyperkalemia. So what will the ECG look like? The ECG will have absent P wave, wide QRS wave, and spiked T wave. Remember this, it is very important. It was also a question for BCSE. So quick summary: you need to know the clinical signs, the hallmark signs: vomiting, diarrhea, PUPD, hypovolemia, bradycardia. Blood picture will show hyperkalemia, hyponatremia. The ratio of sodium to potassium will be less than 27:1. There will be increased 1 creatinine. The signs may be similar to liver disease. There is hypoglycemia. It's very important. Now for diagnosis, ACTH stimulation test, and the treatment has already been summarized. So that was all for Addison's disease.